Good morning, everyone. Welcome back. Always good to see you. Good to see faces. I saw a wave there. Hi, Sarah. We're so excited to have Katie speak to us and with us today. But a couple quick announcements before we start. Katie Arlinghaus is the first of our three newest faculty to be speaking this fall semester in our seminar series. These three outstanding new faculty joined us in 2020. So we are making up time and trying to get to know them better and their work better. So in the coming months, we will also have seminars from Abigail Johnson and Sanaa Zediga. So we're really looking forward to that. Next week is going to be what we've termed in our division an in-service. And again, we're really looking at that as a way of getting hands-on experiences or speaking about hands-on experiences and tools and skills that we can build to improve in the ways that we want to improve with regards to research, teaching, and DEI activities. So next week's in-service will be on how to write winning training grants, and that will be presented by our internal research committee. And there will be a panel of speakers who have successfully obtained training grants at varying levels, meaning at different parts of their career and through different NIH mechanisms. It will be focused on NIH training grants. And we will have perspectives from both the student applicant, or in some cases faculty applicant, as well as from their mentors. So I hope you can make it if you're interested in writing a training grant for yourself, or if you're interested in writing more training grants with your students or trainees. Following that, on October 22nd, is Ryan Demmer's return to our seminar series. We had such a wonderful response from the first seminar with Michael Osterholm and Ryan Demmer that we are asking Ryan to come back and speak about his own work. And there might be a triumphant return by Michael Oakes himself. So Michael Oakes, we are planning to have Michael Oakes as the moderator for Ryan's seminar on the 22nd. And then to round out the month will be our great maternal and child health alum and senior executive vice president of Planned Parenthood, Lauren Gilchrist, who will come to speak with us about the changing landscape of reproductive and sexual health in Minnesota, according to changes nationwide. So I hope that you can make these upcoming seminars. So back to Dr. Katie Arlinghaus. Dr. Arlinghaus's research and teaching activities are focused on bridging the gap between research and public health practice to address health disparities in obesity and other nutrition-related diseases. Her current studies achieve these goals by first utilizing the school setting to provide basic behavioral treatment and prevention for pediatric obesity. Second, identifying predictors of obesity intervention response to optimize the tailoring of interventions. Third, they investigate the role of parental influence on pediatric weight-related behaviors, such as eating and physical activity. And lastly, they address the disproportionate challenges to preventing and treating chronic disease experienced by historically marginalized populations. So I'm so glad to have Katie speak with us today about her work. Welcome, Katie.
Thanks. So happy Friday, everybody. We're gonna get started today with a little poll. So Jeff, can you pull it up? I am curious to know what you all think about averages. We're gonna talk, my presentation today is about nobody is an average. And so I wanna know where we're starting from. So Jeff, when you feel like a lot of people have participated in the poll, go ahead and show us the results.
We'll give people a couple more minutes here. There's a fair bit of reading for them. about half the people have responded so far.
All right. Nothing like starting a Friday with a survey, right?
We're up to 80%, so just a little bit longer.
It's okay if we don't make it to 100. 80 will be good enough.
All right, I usually figure we shoot
Sorry,
for
I'm
more
not
than
very
80%
patient.
in public health.
You think we should get a better response rate?
Looks like people are done, so I will pop the results up here.
Let's see how we're feeling. Maybe you guys go on a date only if you're super bored, if you thought they were average. You're indifferent. Average means indifferent to a painting. And oh, kind of 50-50 chance, not looking good. But nobody is really saying that average is aspirational. We're kind of on the same page there. And so let me go ahead and share my screen and we will get going here talking more about this. So that poll is really a little bit silly and goofy, and I like puns. And so I'm talking about averages today in terms of a mean, but nobody really likes being called average and nobody likes being called mean. But my point with all of that today is really that nobody is an average. And we've known this for a long time. So B.F. Skinner says, prediction of what the average individual will do is often of little or no value in dealing with a particular individual. And so before I started this job, I was practicing as a dietitian, and I used to be able to work one-on-one with folks. And I would say, you know, okay, hey, based on what we've talked about so far today, I think that this diet plan is really going to be a good place for us to start. And then we'll check in and see how it's going. We'll reassess until we finally find what will work for you. And that's really challenging to do, though, at a group level. And I think that that's one of the most exciting parts of public health, too, though, because with trying to help more people at once, we get to not just help one-on-one, but also try to help make families and communities healthier as well. So that first question in the poll before we keep going today, we was talking about, you know, going on a date and someone being average. And so going into the weekend, it's Friday, I've got just a little bit more advice about dating going into the weekend. And we know that we don't want to date someone who's average, but I also would say that if you're on a date with someone and you're having a beer and a burger, and you maybe don't want to, they ask you, you know, what do? You maybe don't want to respond, hi, my name's Katie, I'm a dietitian, and I research how to prevent and treat obesity in a community setting more equitably. That's not a good way to get a second date, right? People usually get a little weird and don't finish their burger all the way. And that's a different talk. Maybe it's, you know, me and dating, totally different talk. But I think a lot of it has to do with we're uncomfortable talking about weight, and everybody kind of thinks about weight and obesity. We're all familiar with it, but it means something different to different people. And so we often will conflate obesity with how someone looks, or we stigmatize each other's weight. And we talk about people being obese when they have obesity. And so Michelle Obama, really brought childhood obesity to the forefront of everyone's attention. And I think a lot of times obesity gets termed, talked about in terms of a war, or, you know, on this Newsweek article, a fight. And It is in a sense that it's a really difficult challenge addressing obesity. And in that sense, it's going to take a lot of work. It's going to be a fight. But what I think gets really lost in that analogy is that this fight, the common enemy is the disease of obesity and not the people. The people are the reason that we are fighting, and they really come first. And so I'm starting my talk today. I really want to be clear because I'm going to talk about obesity. And I want to be clear because we have different thoughts and relationships with the words weight and obesity, that when I'm talking about it today, I'm talking about a disease characterized by excess adiposity. And having excess adiposity in and of itself is problematic, and left untreated leads to dysregulated metabolic pathways and the development of a multitude of diseases, atherosclerosis, hypertension, type 2 diabetes, et cetera, et cetera. The list goes on and on. The other reason that I think obesity gets termed as a crisis or an epidemic in the news a lot is because of its prevalence. So about 1 in every 5 kids in America has obesity right now, and that's a lot. And we don't expect that to decrease anytime soon. So we know that during this pandemic, the rate of BMI increase has been about double what that we would expect. And this is especially happening among our school age kids and those who already had overweight or obesity prior to the epidemic, or the COVID epidemic. The other thing I'll say about prevalence is it doesn't mean crisis though, right? There are a lot of things in this world where they're highly prevalent. Like we've got a lot of people with brown eyes in the world and we're kind of cool with it, right? But we're not cool with childhood obesity because kids with obesity have a similar quality of life as kids undergoing chemotherapy. We don't have great treatments for childhood obesity. And so we know that when you have obesity as an adolescent, it's likely that you're going to keep having obesity as an adult. And where prevalence does become a crisis is that our high prevalence of obesity is not equally distributed. It's disproportionately affecting our marginalized communities. The other reason that prevalence is so important, though, is it determines our action. I talked earlier working about how as a dietitian, I worked one-on-one with individuals, and we can't do that and expect their prevalence of obesity to decrease. And that involves a lot of challenges. Our communities are not homogenous. When we're working with families and kids, everyone's coming into us at a different starting point with different health needs and different cultural backgrounds and different economic backgrounds. And this makes it really challenging. We have this big question of how do we tailor interventions to be meaningful and impactful at an individual level, but give that intervention at a group or a community level so that we can reach a lot of people. And so I'm going to talk about some strategies of how we're doing that today. And first, though, I want to mention, as Ruby said, I do a lot of my work in school-based interventions or in schools, and that's because I love working with kids and that's where kids are. But the really great thing about schools that I think needs to be pointed out is it's a really good spot to intervene with our underserved youth. And so a good example of this is the Healthy Hunger Free Kids Act. So an analysis of this act, this was the legislation that required nutrition guidelines to really be amped up and be more strict for school meals. And so this study done in 2020 found that there was no significant association between that legislation and childhood obesity rates overall. But there was a big difference for children who live in poverty. For those children, the risk of obesity declined substantially each year after the act was implemented, so that they predict that the obesity prevalence would have been 47% higher in 2018 if that legislation hadn't been implemented. And so I say this to just show that what we're doing in schools is critically important, especially for our disadvantaged populations. And so we're going to talk today now about 3 strategies that we're working on to address this issue of moving past the average of a group and making sure that we're meaningfully impacting individuals. So the first strategy is one that I bet a lot of you are familiar with. It's a community health worker model, or a promotora in a Latino community. And so a promotora is someone who is familiar with the population that they serve. They're usually really well-respected members in the community that you're working with. And what they're able to do that's so great is they're able to communicate a health message in a really relatable way. And that is really valuable when we're talking about culturally bound health behaviors, like very personal things about what you eat. The other building from a promotora, though, I said I work with kids. And so who would be like a promotora in the world of a kid? And that's a mentor. That's the older youth, because kids want to be that next stage, right? They're seeking independence from their parents as they turn into teenagers, and peer perceptions are so important, right? And so kind of like a promotor, older youth in a school district are familiar with the context of that school. They understand what the younger student is going through, and they can help them in a way that they can help relate health messages in a way that maybe an adult can't, or a kid not from that, district, the school district. So if you put those together, you get a Companero, which is a buddy. It's social support, right? And we trained high school students to be mentors or be compañeros to middle school students to do an intensive lifestyle intervention in their PE class. And so we compared groups. We had one group where the PE teacher led the intervention compared to a group where we had the PE teacher plus our compañero mentors lead the intervention. And what we found is that the group with compañeros significantly outperformed. Those students had significant decreases in BMI-Z score compared to the kids who just had the intervention led by the PE teacher. And I think really importantly is not just the difference between those groups, but that those results were sustained at a year with the compañeros, and with just the PE teachers, you start to see that uptick in weight. And so myself and my co-PI Barb McMorris and Nancy Sherwood and Sarah Espinoza, we recently got a grant to kind of build from that project and do a demonstration project, really looking at, could we use this mentoring model and expand it to include college mentors? Could we do that to integrate some social emotional learning into a physical activity and nutrition after school program? Would that help us tailor and relate to kids at a group level? And so this is a super shameless plug, but we're hiring, we're just starting this project. And so if this approach of mentorship and community health worker type model is interesting to you, and you know someone who might make a good college mentor, or you would want to be a college mentor, please send them my way. So my email's here and it'll be on the last slide as well. I would love to talk to you more about this project that we've got going. So for this project, what we'll end up doing is we will look at students who had our mentoring after school class compared to students who don't receive our mentoring after school class. And we're going to compare their mean outcomes. And we hope that we're going to find a difference between our intervention and control groups. And that's great. And that's happened in other school-based interventions. And the next step then is you're like, okay, that worked in the short term, but what about long-term, right? I was talking about with the Companero intervention, I'm really impressed that that lasted out to a year. That was really exciting to me, comparing those groups. Longer term matters. And so when we think about maintenance interventions, that's a really great next step of this kind of research. Another really important great step of this research is the urgency of obesity is such that if we've got something that's working in the short term compared to doing nothing, compared to control, let's get this out to more kids. So how can we disseminate our research from one school into others? And that's a whole other body of, dissemination science. And it's really tricky because the thing is, just like there's not really an average person, there's also no average school, right? Just because it works in one school doesn't mean it's going to work in another school. And now both of these lines of research are critical to advancing our understanding of obesity and intervention, but neither of them address this issue we have of heterogeneity of response to our initial interventions. So remember, nobody's an average. Right now, we're overlooking children who respond suboptimally to an initial intervention. So even the most effective interventions always have some individuals with suboptimal responses. And I think we really need to stop overlooking that. So this kind of variation is really widely acknowledged, right? So our guidelines for doing randomized controlled trials think about this in terms of attrition and recommend doing intention to treat analyses, because there's this idea that maybe we're seeing that difference between intervention and control just because a lot of the individuals that the intervention wasn't working for, they dropped out. We also see this with the guidelines for the FDA to approve drugs. So you have to have not just a statistically significant threshold of weight loss, but you also have to meet a proportion of subjects who reach that threshold. And that threshold proportion needs to be reached more in the active control group than the placebo group. But we don't really do this with kids. Right now, among adults, we'll see that response is reported. We have, a 5 to 10% weight loss is considered clinically meaningful. And so a number of interventions will start to report the number of participants or the proportion of participants that meet that threshold of weight loss. But we don't really do this among kids. So I'm finishing up a review right now of school-based studies and looking at who reported response and how did they define response in those interventions. And only about a quarter of school-based studies that met the inclusion criteria for this review report response. And that's even a little bit generous because 4 of those 5 studies came from the same research group. And so I think one of the reasons that we don't really see response being reported so much in pediatric work is that it's really hard to define response or understand what a clinically meaningful threshold of weight loss for kids would be because kids are still growing. And so there's some work going on to try to define that right now. And there's seems to be kind of different possible definitions that it could be. And so what my message to you while we wait to really think about, what would be a clinically meaningful level of weight loss and what would be meaningful to happen in a school. But to just say, okay, we need to make sure that we have a goal for our intervention, right? So what would it be to say this individual was successful in our intervention? And then whatever that is, maybe it's a weight outcome, maybe it's a physical activity outcome, maybe it's a quality of life outcome, but whatever that goal is for being successful as an individual, track it and decide what proportion of participants in the intervention are meeting that goal. The next strategy is really addressing, okay, well, we know we have we're tracking response. We know because we're tracking response that we have some students who didn't respond to our intervention. Now, what can we do for them? So the next strategy is how can we provide an additional intervention option for kids who are responding suboptimally? And to do this, one approach that we thought of is to adapt the stage treatment guidelines from a clinical setting to the school setting. And so these start with prevention plus, and in the school setting, that's really just the school policies and programming going on. And I feel really confident with that parallel. So here on this slide are all the components of prevention plus, and we could talk a lot about inconsistency between, policies in a school and what actually gets implemented. But overall, schools are really providing this function. And we have evidence of this from our accelerated summer weight gain literature, which really shows that just being in school is protective against weight gain. And so we see over the summer, there's this really consistent trend, especially among kids who have overweight or obesity, where during the summer months they increase and then they either hold steady or slightly maybe even decrease a little bit during the school year. And then again, the summer comes around and then they increase. And so you get this like mountain climb of weight gain or BMI over time. And so some researchers in South Carolina have really started talking about why this is and are coined the term the structured days hypothesis. And this is the idea that just the inherent routine of being in school helps prevent obesogenic behaviors. And I think we're seeing more evidence of this coming out with data from the COVID pandemic of the importance of routines for kids. And so that's fantastic. And being in school is protective against weight gain. But when you have 20% of kids already with obesity, I don't think it's enough to just prevent weight gain from happening. We need to do a little bit more. And so some research we did in Houston really highlights that what you do during the school year matters and can carry over into the summer. So if you look at, this is among students who had an intensive lifestyle intervention in their PE class during the school year compared to students who did not have the intervention, a control group. And so in blue here, you're seeing almost a 0.06 increase over the summer months in the control group in BMI Z-score compared to a 0.01 increase. And so that intervention during the school year really attenuated the weight gain that happened during the summer months. And so where we're going to really start is with that intensive lifestyle intervention in the school. And this is consistent with a structured weight management. In structured weight management, the components are listed here, but they're really similar to the components that were listed for Prevention Plus. And this stage seems, kind of like what it sounds like. It's Prevention Plus with a lot of extra structure, right? More intention to it. And so we did this in students' PE class with an intensive lifestyle intervention. And that's what this study really builds from, is this intervention. It's 4 days of physical activity that's circuit-based, 1 day of nutrition, a whole bunch of behavioral modification strategies. We encourage parent involvement. And then this intervention was really created and developed to align with the cultural norms and values of the school district that we did this in, where most of the middle school students were from disadvantaged economic backgrounds and most identified as Hispanic or non-Hispanic Black. And so this intervention has been repeated multiple times and has resulted in improved BMI Z-scores compared to control for up to 2 years. And so we start there, but then we want to add a third stage because we know there are still some kids who are going to respond suboptimally to the intensive lifestyle intervention. And so this third stage is equivalent to the comprehensive multidisciplinary intervention. And this is a ton of words on the slide, but the big takeaways are in maroon, right? So the differences between this and structured weight management are more contact with providers, greater monitoring and expansion of the medical team, and more parental involvement. And so we did this in a study called Take Charge, which stood for Teens Committed to Health Through Activity, Relationships, and Good Eating. And then the stage 3 component was Recharge. And that was kind of, we asked students to recommit to health through activity, relationships, and good eating. And so we made a comprehensive multidisciplinary intervention in the school by creating family groups that were led by college students. And this allowed us to really amp up all of the monitoring, frequency of check-ins, and a lot of social support we had the research team had regular meetings with the PE teachers and then teachers and administration from outside the school district. And we would talk about how specific students were doing and how we could better support them. And so sometimes this resulted in teachers that, like a math teacher that a student was particularly close with coming into PE and working out with the students, or maybe it was that math teacher they were close with would have a regular check-in and do some kind of goal setting with them outside the PE class. The other thing that we really did was we super increased the amount of parental involvement, the opportunities. So students had homework that they were discussing things with parents. There were text messages going out to parents about what was happening in the intervention. A health screener was sent home to parents that talked about different resources and things going on in the school related to health. A registered dietitian followed up with that health screener to make sure that parents had any questions answered about it, and then invited them to nutrition counseling one-on-one. And so kind of like instead of a parent teacher conference, it was a parent dietitian conference. And so this was a lot, really intensive, right? The overall study design, to take a step back, semester 1, we had that intensive lifestyle intervention. No matter how students did in that, they were randomized then to receive either recharge, that escalated treatment I just talked about, or a maintenance condition, which was called PE planners. And that was really what it sounds like. Students were told they had learned tools during the first semester of how to kind of be healthy, and now they needed to practice it. And so could you make a plan for what you wanted to do in PE class? And then to keep things consistent, both conditions were graded the same. It's their PE class. So all students wore heart rate monitors, and they were graded based on the number of minutes that they were in their target heart rate zone. I talked a little bit about the school district and the demographics, but just to be really specific about it, this happened in a PE class at a charter school in Houston, Texas, that actively recruits students who are at risk of not graduating from high school. There are so many students in the school that qualify for free meals that they meet the requirements so that all students are provided with free meals. And about 48% of students in the school experience food insecurity. And so shown here is just our analytic sample, which was limited to students with overweight or obesity, so that we could model this intervention more as a treatment versus solely prevention. And the prevalence of severe obesity, though, is really substantial at this school and a little bit higher than what you might expect from national data. And so for that reason, as I talk specifically about the study, we're going to be using, instead of a BMI-Z score as the outcome, BMI represented as a percentage of the 95th BMI percentile, or BMI-P 95. So I've been talking a lot about response, and I talked about how we're not sure what the best response should be definition-wise for kids. And the definition we used in this study was based on that American Academy of Pediatric staged treatment model that says weight goals are based on your starting BMI percentile and your age. And most students in our study were older than 12, and most had obesity. So really, when we talk about response, this is a pretty stringent response definition, especially for a school-based intervention where we're expecting a decrease in weight. And so what happened? We really hypothesized based on the literature that, the more intensive of an intervention you get, the better the outcomes will be, the more components, the more frequent, higher frequency. So we thought that recharge participants would have a greater decrease in BMI P95 than those in PE planners, but that didn't happen. So there was no difference if you're just comparing PE planners to those who got recharge in the second semester. But if you consider their response to the first semester, there was a difference. And so we're starting to really see that what happened in that first semester matters, not just like what we've seen in the literature with early response predicting longer term response, but also predicting which intervention might be a better fit for a student to be a part of in that second semester. And so we saw that if you were responsive in the first semester, those are our solid lines, and going down in the first semester, that PE planners outperformed recharge. And then conversely, if you responded suboptimally, then recharge outperformed PE planners. And when I was talking to the PE teacher about this, he was not surprised at all, because he kind of compared this, given the context that this was their class, he compared it a lot to a math class. If you're in math and you're doing really well, the outcome expectancy, if you're thinking social cognitive theory, right? The outcome is, oh, the teacher is going to kind of leave me alone. Like, I'm doing my thing, I'm getting good grades, teacher's going to leave me alone. If you're not doing well in math class, the teacher is going to be on you. They're going to try to offer you more support and help, and maybe do some kind of tutoring or after school work to help you learn the material better. And so what happened when we were in the PE class, with those who were responsive, I think in the first semester, and then we gave them more support, we kind of held their hand more, they were like, wait, but I got this. I need that autonomy. And that's what PE planners allowed them to do. And so I think this is a really important lesson of thinking about also the context that your intervention is being given in. And so, there was no statistically significant differences in our proportion of response. So our next step is to really look at what can we learn from that first semester to predict which intervention, recharge or PE planners, participants would do better in the second semester. And so to look at this, we developed conditional inference trees, and we entered both some baseline characteristics into the model, and then also some characteristics that are happening over the course of the semester. So maroons are the baseline and gray are over the semester. And one of those that might be a little bit new to people is weight variability. So this has been studied more so among adults than children, but has really been shown that greater weight variability, so by that I mean more fluctuations in weight, not having that stable weight trajectory, has been associated with weight gain or obesity among adults. And so we wanted to look at this with kids because we have weekly weights on all of these participants. And so we did that. So greater, with this methodology of how we calculated weight variability, a greater RMSE is going to indicate greater variability. And so this is our causal inference tree. And so I'm going to break this down by looking at the left side of the tree first. So here, the first branch, participants who either decreased BMI 95 or increased slightly were likely to benefit from PE planners the most. So all three of these buckets, PE planners had the advantage. And so we specifically see that those who had the greatest attendance and who had little weight variability had the greatest decrease in BMI 95 in the second semester. And then those who had high attendance still, but also had a high weight variability, had less improvement. And so that indicates, and even less improvement than those who had low attendance. And so that indicates that the impact of this attendance is really attenuated by weight variability. And so moving to the right side of the tree, here you have participants who increased their BMI 95. And so these are going to be the participants who are responding suboptimally in the first semester, and those who had higher weight variability. This subgroup had the highest decrease of all subgroups in the second semester, with a 6.41 decrease in BMI P95. And this group really illustrates that recharge was particularly helpful for students who are non-responsive in the first semester, but then who had high weight variability. And then our last subgroup here is looking at those who gained in the first semester, but then their weight variability was lower. And we can't tell who's more likely to benefit from one condition or the other. And so I think this group really illustrates, that we didn't find the right third intervention stage for this group. And we need to do more work in kind of revising what our next step for students are. So we continued to validate this by doing a cross-validation procedure. And so we split the data roughly into 2/3 training and then 1/3 validation portions. And then the subgroup identification procedure was then fit using the training data and then used to identify subjects that we predicted to benefit more from either recharge or PE planners in the second semester. And so the gray dotted line on the plot is the mean decrease in BMI P95 during the second semester. And so you can see that those who were recommended to get PE planners and actually got PE planners, they had a decrease greater than those who actually got recharge. So kind of like check. And the same thing happened with recharge. Those who we recommended recharge actually did most benefit from recharge. So moving forward, I think it's important to note that none of those baseline factors we entered in the model were in the tree. And so it was really these things that are happening continuously over the semester that were most predictive. And so to me, the next question then is, well, how early could we tell, right? And so this is a super practical question for understanding how we would be able to really realistically do this in the school setting, do a staged treatment model in a school setting, because we need to know things like, okay, well, how early could we set up students' schedules for the second semester? And how soon could we know, because we know we're going to have a lot of staffing needs in the next semester when we're amping up intervention for some students. And so how early could we predict those staffing needs? And then the last kind of future direction thing that I want to just really reiterate is this is a starting point. The strategy here is really this idea of framework of finding a solution, a next step for individuals in community settings for whom that intervention wasn't that beneficial. And what can they do instead of, I think a lot of times we just carry on with our interventions and sometimes blame the people who it didn't work for because they weren't adherent or they weren't, trying hard enough. And I don't think that's true. A lot of the times it's just not the right fit for them and they need something else. And so I think it's really important in community settings that we're working to try to figure out and refine what some of those treatments could look like. And so just to quickly summarize what we talked about today, public health models, they aren't based off a real individual person, but an average. And when we're looking only at means or only at medians, the risk of that is we might really leave people behind. And so we talked about 3 different strategies to approach moving past the average. And so we can work with individuals who are able to really relate to our population. So that was our Companero community health worker mentorship type strategy. We need to start defining our intervention goals and tracking the proportion of individuals who meet them and who doesn't. What would be success? What would be success for an individual in this group intervention? And then our last strategy is to really create and then offer what some next steps for individuals who are responding suboptimally could be. So thank you so much. I would love to answer any questions that you have.
Katie, that was great. Thank you so much. I know we were also excited to learn more about your work. Round of applause. Thanks, Sarah. If you could use the raised hand function, that would help us. Katie, while people are developing their questions, I had one. For the newest CDC funded grant that you have, how did you pick the community in the school, that particular community and school?
Good question. So I'm working with Columbia Heights School District, and that school district is a part of a 21st Century Community Learning Center. I think I said that right. And so it's a really good fit with this grant because they have through that program, have a really robust after school program already in place. and they are incredibly committed to the health and well-being of their students. So I went and met with students. They have a student wellness committee, and they were having Zoom meetings, and students are really interested, especially right now coming off of COVID, with some of the more social emotional health. And so they really jumped at the chance to kind of work with this project.
Sarah.
Hey, Katie, thank you for sharing so much of the background and all the great work that you've done and are continuing to do. This is great. One thing that I keep thinking about is, especially when we're focused on, kids who may be underserved in schools. And I'm wondering if you can talk about anything that's been consistent in the interventions you've worked on in terms of helping them happen sort of flawlessly. So there's like a little bit less or minimized burden on participants and in schools. And if anything sort of across the things that you've implemented has helped make that even easier to input.
You mean less burden on the students and families?
Yeah, I think so, because, anytime we start to talk about young people who are facing maybe heightened challenges, it feels like a lot to ask them to do one more thing.
Mm-hmm. Yeah, so I think one of the things that creates less of a burden on a number of the participants in the interventions that I've been a part of is that they are happening at school. And so that time is already set up for them. And so you're not asking them to do something extra. It's their class, like they got to go to PE. So it's not extra for them. What is really extra is it is just incredibly challenging to get parental involvement in a lot of the school-based interventions. And so we've tried a lot of different things, and so I talked about the kind of nutrition counseling sessions that we offered parents, and that was something I will never do again because it was an incredible amount of work, and we would spend hours and hours scheduling with parents and rescheduling, and they wouldn't show up, and it just wasn't worth the benefit of the added benefit of having parents involved. And so I think what did work better though is doing a lot of like texting and things that were less burdensome to the parents.
Amanda has a question.
Hi, sorry, my camera's not on, but I'm here. I just had a question. I've worked not necessarily with like childhood obesity, but with adults that have obesity or overweight, and kind of done a similar study where there was a certain population, and we kind of tried to meet their needs and whatnot through the barriers that they were facing. And I was wondering if, especially through like kind of critiquing your own methods of how to reach these people, have you like thought about doing focus groups, or is that like kind of in the next steps to look at the people that, didn't necessarily do so well in your study, and then to kind of refine maybe measures that you do, even just talking about, reaching the parents and their involvement, what's the barrier there?
Yeah, I think that's an excellent idea, and I would love to do that. So this study that I talked a lot about at the end of the presentation, it got interrupted by COVID. And so we were going to do that actually, but that didn't happen. But yeah, I think that's a really great point, and would be good to specifically hear from the participants.
Absolutely. And then I had a rather kind of like a little caveat question, I guess. This is like totally in schools, and it's not a lot of extra work and whatnot for the students to participate and that sort of thing. I was wondering if you had thought about reaching out maybe even to like the ones that are in maybe high school or something like that, even to like sports teams. I've worked or I've volunteered with a couple of different schools that have been from like one parent homes, and a lot of kids where I had to drive them home and whatnot. And I always felt like their diet and nutrition was absolutely terrible.
Yeah.
But I was their outlet. I was their person that they would talk to, I was their coach. And I, especially for like, high school, middle school, I know it's kind of hard to do in something like elementary, but reaching those populations, I think also would be helpful. Granted, they have to be on the team, that sort of thing. So that's a little bit different. It's more of a niche, I guess, but.
Yeah, I think you're really right, though, that coaches are really powerful people in kids' lives. And so they have a great influence over their health behaviors, for sure. The other thing is, you were talking, you brought up, I said it's low burden on the participants.
Yeah.
Doing an intervention like this in their PE class is low burden on the students themselves, because they have to have PE, but it is a huge burden on the school staff.
Yes.
And so the intensity in trying to do this with a school by themselves, it wouldn't be, it would take a really special district and teacher to be able to do that. And so realistically, it would be hiring outside folks. And so that's another reason that I'm interested in sustainability of some of these kind of mentorship models of people from the community or college students coming in to provide some of that extra help and support to schools, because schools are overburdened as it is. And so adding something extra is really tough.
Absolutely. Thank you.
Mm-hmm.
Katie, one of the reasons I love having you here is that we have other school-based interventions, which is fantastic. And so I'm wondering if you have any ideas as to how to bring us all together, those of us who have school-based interventions or school-based studies, anywhere from the nutrition group to Rachel Whittam's work that overlap both nutrition and sleep in school-aged children. Any grand ideas for us to move forward and kind of capitalize on the number of projects and ideas we have with related to school-based health?
That's a good question. So one of the huge grand envisioning things would be if we could better predict what students need, what aspects of an intervention students need. So one of the reasons that I think we talk about multi-component interventions being really successful is maybe not necessarily that a student needs all of those components, but that they need at least one aspect of that. And so by providing all of these different components, a student will get the thing that they need. And so if we could work together to be able to better predict which aspects of interventions are work for whom, then we might be able to really work together to kind of tease that out a little bit more and guide where a student should go. The other big picture thing would be to really ramp up our partnerships with not just the school, but then, okay, well, the school working with this community organization, a Y, or also, the school working and partnering with different clinics. And so having a really good referral system and pathways that could decrease a lot of the barriers we have for kids to access medical care or access the programs that they might benefit from. And so some of it, I think, is really a system logistical component to this. And I think that's where public health can really shine, and we could work together to kind of figure out better ways to get kids access to the care that they need. So once we figure out what might work for them, then we'll figure out how to work together to get it to them.
That sounds great. Sounds like we need another pod. Waste health pod. Any other questions before we wrap it up for today? Well, I thank you greatly, Katie. I know that you provided your email. Should anyone have questions after the seminar, or for those undergraduates who may be interested in working with you on this new project. It sounds very exciting, and I hope you get a big response. And I actually hope that you come to our classes to talk about them. So again, I'm speaking for all of us when I thank you for this great presentation, and I look forward to hearing the results in a short amount of time. Take care,
Thanks.
Katie. Goodbye,
Thanks,
everyone.
everybody.
We'll see you next week.